Welcome to High-Yield Eye Diseases, Picture Aid and Overview. This presentation is designed to assist with USMLE, Medicine and Nursing Board exams. It provides a comprehensive visual guide to essential eye conditions. Let's explore these critical topics to enhance your understanding and exam readiness. Allergic conjunctivitis is triggered by allergens like pollen and dust mites, often linked to seasonal allergies. Symptoms include intense itching, watery discharge, and redness, typically affecting both eyes. It is usually managed with antihistamine or mast cell stabilizer drops, such as olopatadine drops. Supportive treatment includes cold compresses and artificial tears. Symptoms improve rapidly with allergen avoidance. Viral conjunctivitis, commonly caused by adenovirus, is highly contagious. It presents with watery discharge, red eyes, and preauricular lymphadenopathy. Typically starting in one eye, it spreads to the other. Supportive care is key, as antibiotics are ineffective. Symptoms usually resolve in 7 to 14 days, though they may worsen initially. Bacterial conjunctivitis is often due to bacteria like Staphylococcus aureus. It features redness, gritty sensation, and purulent discharge. Purulent discharge reaccumulates quickly after wiping. Usually starting in one eye, it may spread to both. Treat with topical antibiotics like erythromycin or polymyxin trimethoprim. Use topical fluoroquinolones in contact lens users. While usually self-limited, treatment shortens duration and reduces transmission risk. This slide compares bacterial, viral, and allergic conjunctivitis. Bacterial conjunctivitis involves sticky discharge and is contagious. Viral conjunctivitis is highly contagious with watery discharge. Allergic conjunctivitis, not contagious, involves itching and is linked to allergens. Recognizing these differences is vital for accurate diagnosis and treatment. This comparative slide helps you differentiate bacterial, viral, and allergic conjunctivitis at a glance. Focus on the type of discharge, laterality, associated symptoms like itching or lymphadenopathy, and treatment approach. This is a high-yield board topic. Uveitis is often linked to autoimmune diseases and infections. Symptoms include eye pain, photophobia, and blurred vision. It can be unilateral or bilateral. Fundoscopy may reveal hypopyon. Prompt ophthalmology referral is essential. Treatment includes steroids and cycloplegics to reduce pain and inflammation. Delayed treatment may lead to complications like glaucoma, highlighting the importance of early intervention. Here we see a classic subconjunctival hemorrhage. It is often spontaneous, presenting as a sharply demarcated red patch on the sclera with no vision changes. It is typically painless and resolves without treatment. Reassurance and artificial tears may provide comfort. Understanding its benign nature helps in managing patient concerns effectively. Herpes simplex keratitis results from HSV1 reactivation. It presents with red eye, pain, and dendritic corneal ulcers. Typically unilateral, it requires antiviral treatment like acyclovir. Avoid steroids in epithelial disease to prevent recurrence and scarring. Recognizing this condition is crucial for appropriate management and preventing complications. Arcus senilis involves lipid deposition in the cornea, often age-related. It appears as a gray-white ring and does not affect vision. Usually bilateral, unilateral Arcus may suggest carotid artery disease. No treatment is needed, but checking lipid profiles in younger patients is advised. Understanding its benign nature is important. Cataracts involve lens opacification, often due to aging. Symptoms include gradual vision loss and glare. The lens appears cloudy on examination. Treatment involves surgical extraction and lens implantation. Recognizing cataracts is essential for timely intervention to prevent progression and restore vision. Glaucoma is an optic neuropathy often caused by increased intraocular pressure. Open-angle glaucoma progresses silently, with gradual peripheral vision loss. A key feature of open-angle glaucoma on fundoscopy is an enlarged optic cup, where the central depression of the optic disc is abnormally large and deep. Acute angle closure glaucoma presents abruptly with red eye, severe pain, headache, nausea, and mid-dilated pupils. Treatment varies from topical medications, such as prostaglandins and beta blockers in open-angle glaucoma, to urgent intraocular pressure lowering in acute-angle closure glaucoma. Early detection and management are crucial to prevent blindness. Diabetic retinopathy results from chronic hyperglycemia, causing retinal damage. Key findings include microaneurysms, dot-blot hemorrhages, hard exudates, and cotton wool spots. In advanced cases, neovascularization appears. Management involves glycemic control, laser therapy, and antivascular endothelial growth factor injections. Left untreated, it can lead to permanent vision loss. Early detection and management are vital to prevent complications. Hypertensive retinopathy is caused by chronic hypertension, leading to retinal damage. Look for arteriovenous nicking, flame hemorrhages, and cotton wool spots. Severe hypertension can cause optic disc edema or papilledema. Strict blood pressure control is essential to prevent progression. Understanding its features aids in early detection and management to prevent vision loss. Retinal detachment is a vision-threatening emergency. It often presents with sudden flashes, floaters, and a curtain-like visual field loss. Causes include trauma, myopia, or diabetic retinopathy. Urgent surgical intervention is required to prevent permanent vision loss. Early recognition and treatment improve outcomes significantly. Central retinal artery occlusion is a sudden, painless, profound vision loss due to arterial occlusion. It is usually due to emboli from carotid or cardiac sources. It presents with a cherry red spot on the macula. Emergency treatment is needed, though prognosis is poor. Recognizing this condition is crucial for urgent intervention to attempt vision preservation. Central retinal vein occlusion leads to sudden, painless vision loss as well, but the retina appears hemorrhagic and swollen, giving the classic blood and thunder appearance on fundoscopy. It's often associated with hypertension, diabetes, or hypercoagulability. Treatment focuses on managing risk factors and antivascular endothelial growth factor injections. Prognosis varies, with some recovering vision. Early detection and management are key to preventing complications. Age-related macular degeneration, or AMD, involves macular degeneration with age. Symptoms include central vision loss and distortion of vision. Dry AMD features drusen on fundoscopic examination and slower progression, while wet AMD has rapid loss due to neovascularization and hemorrhage. Risk factors include age, smoking, and family history. Treatment varies between dry and wet AMD with lifestyle changes. Antivascular endothelial growth factor therapy is used for wet AMD. AREDS2 vitamins such as vitamin C, vitamin E, lutein, zeaxanthin, zinc, and copper help in dry AMD. Papilledema involves bilateral optic disc swelling due to increased intracranial pressure. Causes include intracranial mass lesions and severe hypertension. Urgent neuroimaging is required. Optic neuritis is often linked to multiple sclerosis. Symptoms include unilateral vision loss, eye pain with movement, and reduced color perception. Fundoscopy may be normal or show optic disc swelling. Treatment involves intravenous corticosteroids. Vision typically improves over weeks, but multiple sclerosis may develop later. Please like and share this video, and don't forget to subscribe.